Sanjiv sir. It's been a very privilege for us that you have joined us, and all we have learned much from you when we were at NHM, and also we have Dr. I can see Dr. Italia, who is a Padma Vibhushan, and he has been a mentor for us, and Dr. J.S. Arora, a very good colleague, and been doing a very hard work, and lot many people from different parts of the country has joined us today. Very fortunate with this program because we can see the people from ESIC hospitals have joined, from the states they have joined. So one person from the states, ESIC hospitals, then our MHA hospitals, Morth hospitals, everybody has joined from the different parts of country, and it has been very kind of Dr. Sanjeev that he has consented to give us time for this Nirantar Shiksha, which we have been organizing for last 1 year. This was an initiative which we initiated at NHA, that we wanted that it is important. And when we talk about management, we keep on talking about the health benefit packages, how it is going to help the societal at the large and at the last mile also. While we were talking about these health benefit packages, now it was also a time when people should understand what is preventive health. And when we started talking about the preventive health, people could understand that what exactly they have to do while not getting into the troubles. So that was an idea, and we have taken much topics about the health disparities, then health economics, which is very important, and also about the preventive measures which needs to be taken alongside. So we are, I mean, if we talk about all these things, India like is a land of diversity, not in just terms of language, culture, tradition, but also in the geography and development. From towering towards Himalayas in the north and coastal plains of the south, from the arid deserts of Rajasthan to the lush forest of northeast, our geography is varied in the and it's very vast. However, with the diversity come disparity, infrastructure, education, healthcare, employment, opportunity, even the basic living conditions are different. India, we know, is one of the finest, we have the finest medical institutions in the world. Like we have AIMS, and Dr. Sanjeev is an alumnus of AIMS, and yet access to even basic healthcare remains a daily struggle, especially those in remote areas, rural, tribal regions. While urban regions enjoy multi-speciality hospitals and well-equipped clinics, many villages lacks a primary healthcare center which is at the walking distance. And sometimes it is very difficult to have these access also, especially when I was in tribal affairs as an advisor tribal, I could have, we have seen that from our own sides that there was a lot of many issues by tribal people because of their mistrust and also because of the excesses. They were not able to travel to our health facilities even. That was real a challenge. So how to get all these people along when we have such a good system in India? When we talk about National Health Authority, or we talk about NHM, or we talk about Rogi Kalyan, whatever, there's so many schemes which are there, but yet there is a challenge. A pregnant woman in our urban hospital may have access to skilled care and modern equipment, while in the remote, I have to travel miles simultaneously to deal with the trauma during the birth. And I have seen so many, well, we were taking care of the blood services at NHM and at NACO also, we are finding that these ladies who were supposed to give birth to, they didn't have these facilities at their places. So this concept of blood storage center came in, and we started doing the blood storage, but still there are a lot many issues where we need to have these facilities as the PSC level also, when we can have these storages, when we can have much of the places where these facilities are much needed during their pregnancy. COVID-19 pandemic exposed even the widen this gap. It taught us that the healthcare inequality is just not a rural problem, it is a national challenge and demands attention, collaboration, and long-term policy reforms as well. Today, with this webinar, our goal basically is to understand the geographical disparities, health disparities, identify their root cause, and discuss ways to bridge the gaps through innovation, community engagements, government support, and most importantly, awareness. I again extend my heartfelt to our distinguished speakers, Dr. Sanjiv Kumar, our healthcare professional, educator, and he says that I'm a learner, a student. His presence is a sign that we care and we are willing to learn and take actions. Vidya Vinay Sampay Brahmase Gay Hastani thus says equality and non-discrimination using to all well-beings equal respect and compassion applied to geographical disparity. It reminds of that every citizen, regardless of whether they live in a city or remote village, deserves the equal and care. So now, coming to back to Sir's details, when it is really a great thing that today Dr. Sanjiv has joined us, who is basically alumnus of AIMS Delhi with 41 experience in public health across 29 countries. His work is public health expands from the deserts of Rajasthan, Muscle villages of Kenya, former Soviet countries in transition, conflict-torn areas of Iraq, Somalia, Tajikistan, and Uganda. You can find different countries he has been working for, and different. I mean, when you work in different countries and country like this, there are so many disparities itself. He started as medical officer in Indian Army and then worked at grassroots level at the primary health centers in Haryana and urban slums in Delhi. He taught preventive and social medicine as lecturer in University College of Medical Sciences, New Delhi. He joined UNICEF and worked for 22 years as health specialist in India and a chief of child survival and development and senior advisor in Iraq as well. He was in Kenya also, Uganda, Somalia, and advisor for 22 countries in the Asia, Central Eastern Europe, and Baltic states. In the course of gaining vast experience, Dr. Sanjeev Kumar has published more than 100 papers in scientific and popular in chapters and books. His current focus is on leadership, strategic management, health, and health research. And we have been very fortunate because we have worked with him at NHM when I was at NHM. We were very fortunate to learn from him, and he was a good guide and a mentor to all of us. So thank you, sir, for joining us and taking this very important topic, which is geographical disparities in access to healthcare. We would like to invite you, sir, say thank you that you have come up from there, and sir is in US today. It's a very early morning for him. So a very good morning to you, sir. And we also, as I said, we also have Dr. Italia, who is with us from Gujarat, and Dr. J. Sarora. Everybody can be seen here. So it is our privilege if everybody has joined us. Thank you so much, sir. And we will request you now to start with the presentation. Thank you so much.
Thank you so
Thank
much,
you so much.
Vinita ji,
Thank
for
you so much.
connecting me. Do you hear me clear and loud?
Yes, sir. We can hear you, sir.
Hear you. We
Okay.
can hear you.
Thanks for connecting me from the other end of the world. And thanks to technology, these things are possible. And thanks, Dr. Aurora, for roping me into it. आप पता नहीं कहाँ से ढूंढ के निकाल लाते हो. Thank you. We will be talking about geographical disparities in access to healthcare. And when I was told by Vinita ji to talk on this topic, I was wondering how do I approach it? Should it be a typical academic session or should it be building in my experiences of working in about 30 countries across the world? So I thought I'll have a mix of the two so that you hear stories about how some of the issues related to disparities came up and how these were addressed in other parts of the world as well, in addition to the diverse land of our motherland, India, which itself is, giving us very rich experience of different contours and different types of approaches we need to adopt. So with that, I'll give you an overview. And I suggest you ask me questions at the end, but in case you don't follow something, you can ask a question in the chat box and Vinita ji or somebody, if I overlook it, can point out that there is somebody who wants to ask a question and then I will stop and address that question. So this is my journey across the world, starting in PHC in Haryana, or rather before that as medical officer in the army, then PHC in Haryana, working at national level, state level, and international level, and in academics as well as a teacher in preventive and social medicine in UCMS and in AIMS, and then health management as director of IHMR. NHSRC gave me a good insight into policy and program delivery, where I worked as director, executive director for 3 years. And then my current passion is training in leadership in health, medical education, health research, and public health. I have trained about 1,300 health professionals in leadership from medical officers to vice chancellors of medical university, and that's my current commitment, that we need to build leadership capacities in public health professionals, which I thought was lacking. This is what I loved when I heard it is called Nirantar Shiksha. In fact, not just public health, everything in life is lifelong learning. It starts with a in your early childhood. This is my granddaughter. When she was 3 years, she was learning reading and writing, and on the other hand, it is me holding a textbook of community medicine brought out by Indian Association of Preventive and Social Medicine. And when you look at lifelong learning, you keep reflecting throughout your life. What have I learned? What more is there for me to learn? And then you identify what more is there to learn or what more is there to brush up. And you act. And then you keep reviewing again. And then you come to know what else you need to know, and the life, this cycle continues. We will be talking about geographical disparities. We will talk a bit about equity and access issues. We will look at the barriers and look at some global and domestic health initiatives, and what we can do to improve future strategies to improve access. And then we will take some take home messages. There are broadly five barriers. One is socio-economic status, and National Health Authority through Ayushman Bharat is doing a great job in bringing out that barrier. We have geographical access. We will go into little more details of that. Then you have lack of transportation. You have cultural and linguistic barriers and lack of health insurance. So these are the five barriers, but when you look at real life situation, there is an overlap. There is no one barrier isolated only in a particular group of population. There is a mix of these barriers. So when it comes to real life, we will be looking at these as intertwined. Theoretically, yes, we can look at each one of them in isolation. Geographical disparities. Uh, these refer to uneven distribution of services across different regions, especially for the disadvantaged rural and remote areas. Individuals face many restrictions for long distances, fewer healthcare providers, and limited specialized care. And as I said earlier, these are intermingled. To give you an example of when I joined UNICEF in Rajasthan, I encouraged SMS Medical College to look at maternal deaths which had taken place. So the mothers who died in pregnancy related causes, they identified 300 maternal deaths. And to our surprise, most of the deaths was from the slum areas. We thought that the type 1 delay in taking decision and type 2 delay in traveling will be more important. But to our surprise, we found that most of these deaths were from nearby slum areas, the poor habitation. So it is not necessary that distance is always important. There are other factors which complicate the issue. Uh, how many of you watch this Gram Chikitsalay serial in?
I've seen.
Okay, and anyone else? I'll be asking you questions. So this medical officer, Vinita ji, you don't have to answer. I'm
Oh,
looking
no,
at
sir,
my
not at all.
So a new medical officer joins primary health center, and this health center has been abandoned for many years. There were doctors posted, but hardly anybody went there. Most of them went, joined, and then they went back before night. So Can any one of you tell me what was the difference between the Jhola Chhap doctor and the doctor who was posted as MOPHC? What was the difference? The second point is pointing in that direction. And he goes to a social function in the village, and he talks to the Jhola Chhap doctor, and he gives him a very good piece of advice. So, what was that advice he received from Jhola Chhap doctor, from which he learned? Anyone, you can either write in the chat box or you can uh, unmute yourself and speak up.
Nanda,
Yes, they can unmute themselves and they can say the answer.
it. You can also.
Get involved with the community.
Nanda, Samnima bhai
Yes,
wants to answer.
नहीं संजीव सर, आपका फोन म्यूट में है। इधर फोन या लैपटॉप आप अनम्यूट कर सकते हैं। नहीं तो आपका लैपटॉप वाला आप कर सकते हैं। संजीव सर, आप अपना लैपटॉप
Nanda,
अनम्यूट कर
there are
सकते
two
हैं।
people who want to answer. They have raised
यस
their hands.
यस पार्थिव, यस यू कैन। Participants can unmute themselves so they can unmute and can answer the question.
Box. It's difficult for them to unmute and do. Sanjeev sir, link has been lost or what? Nanda,
यस संजीव सर, आप आपका लैपटॉप नहीं तो फोन अनम्यूट कर सकते हैं।
आवाज नहीं आ
हाँ
रही
अब
है ना?
Is it okay?
Now
यस
it's
यस नाउ इट
better.
इज।
Okay, my apologies. I didn't realize I had unmuted myself.
ओके सर।
पार्थिव कुछ कह रहे थे, पार्थिव ने लिखा कुछ?
लिखा नहीं, उन्होंने हाथ उठाया था, फिर वो बोल नहीं पाए, शायद अनम्यूट नहीं कर पा रहे हैं सर। लास्ट में
Okay.
मैं दोबारा से उनको पूछूंगी। There were two people who raised their hand, but answer because maybe कर नहीं पा रहे हैं अनम्यूट अपने साइड से, that's the reason.
नाउ दे कैन अनम्यूट।
This Kok
Okay.
Gokani, that is also he also wants to answer, but asked to unmute.
Please.
Yeah, this is Dr. Pramod here. Can I answer?
Yes, Dr. Pramod, please.
Get involved with the community. That was a main message I think the Jhola Chap doctor had said.
Okay.
Yeah. उनके सुख दुख में उनके साथ रहना होता है।
So Dr. Pramod has answered it, sir. Dr. Pramod Jacob, from where you are, Dr. Pramod, can we ask you from which place you are?
I'm based in Bangalore now.
Okay, great.
Anyone else? Otherwise, I'll tell you my own story.
Mr.
somebody has written Somebody has written in the chat box, Jholachap doctor don't have any degree. He did his practice under physician and helper or compounder has started doing practices with little knowledge of medicines. So that is how she defined Jholachap.
Have Parthiv spoken up? और पार्थिव का हाथ अभी भी दिखाई दे रहा है, पार्थिव कटारिया.
No, so many people want to answer, sir. One.
Okay. All right, and I'll share you my own stories. I'm sure all of you who have worked at PHC can relate to it. I was posted at PHC Dayalpur, a PHC in Haryana under All India Institute of Medical Sciences Field Practice Area. So, and I was medical officer in charge as senior resident, and they were interns and junior residents working with me. So, and antenatal clinic used to be twice a week, and a common advice all of us give to predominantly vegetarian is eat दालें खाया करो, lentils, and then we also used to tell them vitamin A के लिए papaya खाया करो, and most of them will react. Sir, तासीर आफ्टर इफेक्ट इज हॉट. तासीर गर्म होती है और पपाया की भी तासीर गर्म होती है. बच्चा गिर जाएगा, हम तो नहीं देते अपने परिवार में किसी प्रेग्नेंट मदर को. एंड वी एज टिपिकल डॉक्टर्स हाईली from one of the best institution will rebuke them. हम बता रहे हैं ना, ये कोई गरम तासीर नहीं होती, कुछ नहीं होगा, तुम खाया करो. And in the evening, when we went out of the PHC, we found many pouches of iron folic acid tablets thrown at the exit of the PHC gate. And I was very disturbed, and I asked the village sarpanch, Sir, why are they not taking the medicines we give them? अलग से पाउच खरीदते हैं, उसमें दवाइयाँ डाल के उनको देते हैं, फिर भी वो फेंक जाते हैं. So he started laughing. He said, Sir, गांव में ये बात चल रही है कि इतने पढ़े लिखे डॉक्टर हैं, हम अनपढ़ हैं, हमें इतना पता है, इनको तो इतना भी नहीं पता. एंड दैट मेड मी गो टू नई सड़क. दिल्ली बुक डिपो होता था उन दिन, अभी भी होगा. वहां से मैं चरक संहिता खरीद के लाया, 2 वॉल्यूम. एंड देन आई रियलाइज कि नमक की ठंडी होती है, दाल की तासीर गर्म होती है. तो देन वी ऑल डिस्कस एंड वी स्टार्टेड टेलिंग देम दाल में नमक डाल के खाया करो. तो कहते सर दाल तो नमक डाल के ही खाते हैं. तो हमने उनको बताया कि इसीलिए नमक डालते हैं क्योंकि उसकी जो तासीर होती है ना, वो जो गर्म तासीर है वो खत्म हो जाती है. उसी तरह पपाया, उसको भी थोड़ा सा नमक डाल के खाया करो. And then our advice got accepted, and our iron folate tablets which were thrown at the exit of the PHC, वो बेचारे शर्म के मारे हमारे मुंह पे तो नहीं मार के जाते थे, पर PHC के बाहर के जाते थे. So you have to have respect for the socio-cultural practices and don't have it outright scientific and blunt. There are many aspects which we as students of modern medicine do not know. Sociology, cultural aspects, Ayurveda, etc. We are not taught that. I believe now National Medical Commission is including in MBBS curriculum, but we have to make sure that we respect them. So even if the patient is next door to your PHC and you don't respect socio-cultural practices of the community, your advice will not be taken. And as a medical officer, PHC, you are always under constant watch of the villagers and patients, and they talk about each one of you when they go back in their community. So it takes time to build relations. So gradually, I was invited to all birthday parties and weddings in the village. By the time I left, I was a very popular medical officer who was going around the village meeting people. Whenever I was not coming to Delhi on the weekend, we'd join their social get-togethers. So this is another aspect we need to learn. Our social skills are important. We say we are professionals and we want to stick to professionalism. That is very fine. But you need to be connected to the villagers so that you are accepted in the community, and then your disparities in healthcare will also come down. So I've told you about it. Then how many of you have watched this movie, Sicko? Aman. Who else? Okay, good. Anyone who has watched this movie can tell us what are the messages from this movie. And this movie is about healthcare in developed countries and how people get marginalized. These are the countries which are spending a lot more money than we spend in India. But even there, people are marginalized. They don't get health care which they need. Komal? Komal, you can unmute yourself and tell us what you saw in this movie. What were the messages on disparity? Or anyone else?
If anyone, they
No
can write in the
volunteers?
chat box or they can raise their hands.
Yes, please. All right. If nobody is volunteer, I'll give you a brief about this movie. This is a movie which was made in 2007 and released in Canada. Michael Moore is a social satirist. He picks up issues which are not good in the society and makes movies on that. He has also written a few books as a social satirist. And this movie starts with the heroes of 2611, those who helped saving lives, and unfortunately, when when the twin towers collapsed, a lot of dust was generated, and they inhaled a lot of dust, and many of them were suffering from chronic respiratory diseases and were on oxygen. Unfortunately, there was no free medical care. They were out of job because they were not medically fit and they were not able to look after their expenditure for their chronic obstructive lung disease. So this gentleman picks them up because he had heard Guantanamo Bay, where they keep the most dreaded terrorist in jail, thinking that medical care in Guantanamo Bay is free. So he takes them in a boat to Guantanamo Bay. Obviously, who will let them enter? It's a high security area. They shoo them away. And then they go to a nearby country called Cuba. And in Cuba, they come to know that these 2611 heroes have come. They garland them, give them a lot of gifts, take them with them. Oh, you are not well, you are not suffering from respiratory diseases. Let's take you to hospital. So they are admitted in a hospital. They are given the best available treatment. And when they were leaving from there, they give them medicines for 6 months so that they don't have to buy medicines. Then they go to he takes them to not them, but he goes to Canada and looks at the health systems. Comes across a lady who was suffering from a cancer and was not being treated in US. She is a US citizen. She goes and gets married to somebody in Canada, gets free treatment for her cancer. Then going to France and UK to look at how the free medical care being provided in these countries is much better than very expensive medical care in United States of America. I remember an instance in the movie. He goes around a hospital in UK and he says, somebody must be charging some money somewhere. Let me go around the hospital. And he's very happy when he come across a cashier counter. He's very happy. Oh, finally, I know a place where they take money. So he goes to the cashier and asks the cashier, for what do you charge? He said, no, we don't charge. We reimburse the taxi fare to the patients who come for treatment to the hospital. And I remember my younger daughter was studying in England. So anybody who became sick, three, four girls will go with that person because the taxi fare will be reimbursed. After getting treatment for the patient, they will go to the city, uh, have a meal or something there, and then come back to their hostel. So US, one of the most expensive healthcare systems in the world, there are a large proportion of people who are marginalized. They do not get medical care because they are not covered by the social insurance provided by the government, Medicaid and Medicare, and not by the private insurance, since they cannot pay the premium for private insurance and they are not eligible for social insurance, and very large proportion of them are suffering because of that. So it is not the money you spend. I don't know exact figure now. It's around $18,000 per capita per year they spend on medical care in US. And how much do they spend in Cuba? Around $700. So it is not how much money you spend. It is where you spend the money. Primary health care is the focus in Cuba. So if they treat people before they fall sick, so that they don't fall sick, and they pick up patients who are in early stage of disease, they treat them, and then they're able to cure them at much lesser expenses. So we always say lack of money, we need more money. So yes, money is important certainly, but it is more important where you spend that money. You have to keep that in mind. So if you have not seen this movie, I suggest you see this movie, and also see Chikitsalaya. That will also give you some insight into how people are deprived of services. Another story from Rajasthan. This I'll take you back to 87, 88 when I joined UNICEF in Rajasthan. Immunization coverage was 15 to 20%, and we had to achieve 80% coverage by the end of 1990. And it is a tough task in a year and a half to reach from around 15-20% coverage to 80% coverage. What the government did with support from UNICEF and other partners, they looked at demand side mobilization. They mobilized sarpanches and panches. I remember there was a gathering of about 20,000 sarpanches in Jaipur, and we were told to print something so that every sarpanch can take it back with them. So we printed a pamphlet. On the cover of the pamphlet was the picture of a Rajasthani sarpanch with big mustaches, with turban, and announcing, I will not let even one child and pregnant mother go without vaccination in my village. So that pamphlet was distributed. They went back to the village, gave it to all the punch in their panchayat, and made sure that every child, every pregnant mother in their ward is vaccinated. Nehru Yuva Kendra volunteers. We had about 10,000 of these volunteers in Rajasthan, and we talked to them, what can you do, what are the problems? So we told them what are the problems, and ice lined refrigerator deep freezers were not as common as they are today. So there were distances in bringing the vaccine carrier, day carrier with the vaccine. Many of them had two-wheelers. They volunteered, sir, we will go and get the vaccine from the nearest PHC and deliver it to the ANM and the male worker to vaccinate. So similarly, school teachers and children were mobilized, and this 20 questions on immunization I told you about was the pamphlet we printed and distributed to our punches and everyone else who was involved. Government undertook rapid expansion of cold chains so that ice-lined refrigerator and deep freezers for storing of vaccine were available as close to the villages as possible. BCG vaccine, maybe you have not seen that. Rather 80s only, in 90s things had improved. There used to be a BCG technician, about 5-6 of them at every district headquarter. They are the only ones who were entitled to give BCG vaccine. No worker was trained to give the vaccine. So we had a meeting with the BCG technician. They all got scared that our jobs will be lost and what will we do. So and they went on strike. And the director of health services asked their leaders to meet me. So they came to UNICEF. We had a long chat with them over a cup of tea and told them, no, your jobs are not going to be laid off. you will continue to work, but your main work will be to train all MPWs and all ANMs in giving BCG vaccine. And they were giving 21 days of training. So we went through the whole training curriculum, and the first day was tell them about BCG and how it was invented. So then we looked at these things are not really needed. The main thing needed is how to give intradermal injection. So we all agreed that 3 day training will be enough, and then they gave training to the ANMs, and over a period of time, all the ANMs and male workers were in a position to give BCG vaccine. So this is how both supply side and demand side were addressed, and we were able to get a better coverage. Somebody wanted to say something? Okay. Another thing which was done was micro planning, which became very popular during polio eradication as well. So in fact, micro planning for the first time was done in late 80s, when every eligible child and every pregnant mother was put in on a piece of paper, and they were tracked till they were fully vaccinated. So it died down a bit and then came back again in polio eradication, when they had to reach every eligible child was with polio vaccine. This is a story from Iraq. In 90s, late 90s and early 90s, mortality rate in Iraq went up. Infant mortality, child mortality, in fact, maternal mortality ratio also went up. Can any one of you guess why did it go up? Okay. There was first Middle East war in 92-93, when Iraq invaded Kuwait, and then Iraqi forces were pushed back by Allied forces, and United Nations put sanctions on Iraq. Iraq is an oil-rich country. Even today, it's an oil-rich country. They were not allowed to sell as much oil as they wanted to. There were restrictions. And because of UN restrictions, because they couldn't sell enough oil to get all the essential supplies, at times even vaccine supplies was hampered. Excuse me. The infant, child, and maternal mortality ratio went up. There was a huge inflation. The conversion from one Iraqi dinar to a $3.3 came down to $1 to 2,000 Iraqi dinar. So, lot of economic upheaval took place, and people lost their purchasing capacity, and suddenly they were without essential needs of life, and at the same time, government didn't have sufficient money to buy the essential. And I often used to say it is UN sanctions which are killing children in Iraq, not the war. The sanctions are imposed for the rulers in a country, but it is not the rulers who suffer, it is the common man who suffers. So this disparity over a period of time was seen by Iraqi population because of the sanction imposed by United Nations Security Council. All of you are probably aware of this law. It is known to as inverse care law. The availability of good quality health care seems to be inversely related to the need for it in developing countries. And those who want to read more about it, I have given references which you can go to. When you provide services to everybody, it disproportionately benefits those who are better off. Health systems consistently provide higher quality services to the well-off who need it less than those who need it more. So we need concerted efforts to reach out to the disadvantaged groups. If you don't, you will be missing out on the disadvantaged groups. On the right side of the screen, you have advantage group on one end, you have more disadvantaged groups on the other hand, and then you have the gap of unmet need, which is much bigger for those who are disadvantaged groups. So when you have services free for everybody or available to everybody, those who need it more will get left out. So you have to make specific efforts targeting those who need services more than the others. Disparity, every document you look at will be looking at reducing disparity by reaching out to those who are disadvantaged. This is National Health Policy 2017, which was written when I was Executive Director of NHSRC and we were given the responsibility. It says achievement of all health and development goal is compromised if disparity in healthcare are not properly addressed. Equity is one of the basic principles of the primary healthcare approach. Those of you who remember Alma Ata, it precisely talked about equity. Equity is one of the essential pillars of primary healthcare. Similarly, sustainable development goal, you cannot achieve them if you do not address geographical disparities. What is SDG 3? To ensure healthy lives and promote well-being for all at all ages. For all at all ages. It is not mortality reduction or disease elimination. It is to ensure health and promote well-being for all at all ages. And little later we will go into more details. If you ignore addressing disparity, you will create less productive and less resilient population, which will hinder in achieving our goal of a developed nation by 2047. You have seen this picture of equality. When you talk about eliminating disparity, it goes much further. You see in the first three pictures, there is a wall. And when it is reality, those who are advantaged have a lot more resources. They can easily stand on what they have to see the match on the other side of the wall. And then somebody with less resources gets a lesser, higher platform, and those who don't have resources, they cannot even see. Then you want to give equal to everyone. So everybody gets equal. Ignoring what they need. Equity is giving people based on what they need. And becoming impartial and looking at inclusion, you remove the obstacle. What was the obstacle? The wall. So in these two, we have removed the wall. So when it comes to addressing disparity, it is very important for us to look at barriers, not just giving them resources so that they can overcome the barriers. That is important, but more important is look at what are the barriers and remove those barriers so that everybody has equal access to, in our case, quality health care. Geographical disparity, physical environment, geographical location, we all know affects the availability of services and impacts the health status of a population. These are the differences between healthcare access and subsequent health outcome, which are influenced by where you live, your geographical your geographical location. There are at global and within country, you have rural versus urban, you have tribal versus non-tribal, you have various caste groups, you have socio-economically deprived group, you have state-to-state variation, and then you have variation within states. And I'll go a step further and say there are variations within the district as well. There are variation from one house in a neighborhood to the other house in the neighborhood. So there are variation, there are disparities. We need to address those disparities in a way that nobody is deprived of the needed services. You can all share number of presentations of different indicators where you can see variation from one state to the other, for infant mortality, for maternal mortality ratio, and so on. So I'll not be going into details of this. All of you know it. And the variation may be up to 10 times from one state, which is the best of to the other state. For example, in infant mortality, Kerala at 6 and the highest in Madhya Pradesh at 43, which is 7 times more. And on maternal mortality ratio, you have Kerala at 19, and then you have Madhya Pradesh at 173. It's almost 8 or 9 times higher. So there is variation from state to state. This is a slide I will like to spend some more time. Access is the ability, one, to identify healthcare. If a population or an individual is not able to identify healthcare needs, there will be disparity. They identify the need and then they seek healthcare services. They seek healthcare services, they reach where they are supposed to reach at appropriate level. For example, for emergency obstetric care, if you reach PHC, it is of no use. You have to reach a place where you have emergency obstetric care available, maybe at CHC, sub-district or district level hospital. You reach there and then you obtain and use the healthcare services. And you have your need fulfilled. That is when you have access to health services. There are two sides to it, supply side and demand side. What we want to get is equitable health outcome. Supply side is approachability. This is covered by geographical disparity. Acceptability. I gave you an example when our advice was not acceptable to pregnant mothers on what food advice we wanted to give them. Availability. The services should be available and the manpower to provide services should be available. It should be affordable and it should be appropriate. Affordable, we often say that we are providing free health services. Why don't people come and avail? We have to look at a typical family in the village. They are farmers or they are laborers, marginal farmers who have to work in other farms to make a living. They have a few cattle. So if a lady or a gentleman or a baby has to go to hospital, they cannot go alone. Somebody has to go with them. And who will look after the rest of the family? Who will look after the cattle? And who will look after the field? So they have to make alternative arrangement for someone to come and take care of that. It's not like me and you, we will take casual leave from our place of work and then just go away. They have a lot more things to consider before they come to hospital, and that also incurs expenditure, not only medical care. They have to incur expenditure, which is referred to as opportunity cost, to go and avail the services, making alternative arrangements. On the demand side, you have 5 abilities. One is ability to perceive. I see I have a health problem. If you don't see you have a health problem, you will not be able to get services for that. Then you should be able to know where do you seek services, which place you need to go to. And then you should have ability to reach there, transportation or walking over to that particular place. Then you have to incur expenditure. If you don't pay for services, if it is free, even then you have to incur some expenditure. And to give you a story about the ability to reach, there is a PHC called Chhasa. I told you a story about Dayalpur. There is another PHC of AIIMS, which is at a village called Chhasa. There is a village called Dulepur, about I think 5-6 kilometers walking distance from the PHC. So whenever we were breaking for lunch, the patients from that village will walk in and we will say, no, no, OPD is closed. And one day I requested my health workers who were looking after that village to take me to that village. It was about half an hour walk to that village. And there were only 15, 16 families staying in that, I won't call it village, more of a hutment. Uh, and then it was a poor neighborhood. At that time, this is early 80s, they had nobody in their village had a watch. So they would see the sun has come up to this level, PHC must have opened, and they will start walking to the PHC. And by the time they get to the PHC, it is time for the PHC to stop registration or close the PHC. And then we understood what is their problem, and then we stopped saying no to anybody who came from that village. So you have to look at what is their ability to reach a health facility, and is the health facility receptive to provide them the services. So you will not understand some of these implications if you do not see where they stay, what are their work, their living conditions, and how do they manage. And for that person to go back to the village and come again, most probably the person will never come again because he did not receive the required services even after walking in the sun for such a long distance. So we keep that in mind. Then the ability to pay and ability to engage. When they reach the PHC, the doctor should be able to understand what they are saying and should be able to explain to them what they need to do. And I often hear from my educated friends that, oh, illiteracy is a problem. Illiteracy is not a problem for the illiterate. Illiteracy is the problem for the literate because they are not in a position to talk to the villagers in the language they understand. I have become illiterate 3 times in my life. I was posted in Iraq. I didn't know a word of Arabic. I was illiterate. I was educated, but I was illiterate. I couldn't talk to the local people. Then I went to Geneva. Most of the countries were Russian speaking. I became illiterate again because I couldn't speak in language. I needed somebody to interpret and then tell me back and interpret what I was saying back to them. So illiteracy is not a problem for the illiterate, it's a problem for the literate who look down upon the people who did not have opportunity, go to school and colleges like me and you were given that opportunity. So don't look down upon them. Try to understand in the dialect they speak. Every one of them speaks. Every illiterate person speaks. So we need to empower ourselves to understand their dialect, their language, so that we can engage with them and they can take the services which we are providing them. This is more details of what do you understand from accessibility. You have accessibility to the provider, to the organization, to the institution, and to the systems depending on the situation. And what is access is defined as the opportunity to have healthcare needs fulfilled and the ability of the population, of the community, of the household and individual. We will a little later go into more details of we ignore the family capacity to take care of health and discuss more about what we can do at household and individual level. And at the bottom, you have healthcare needs, you have perception of needs and desire for care. You may have perception, but you don't have desire to go and seek help for what you have perceived as a need. Then you have healthcare seeking. You reach the institution. Then you have healthcare utilization. You have primary access and secondary access. Then you have healthcare consequences. You have economic consequences. You have satisfaction if you get good services. And then your health outcomes also improve. And what else do you need? This is a conceptual framework to understand better on disparity and access. transparency, outreach, information, and screening in approachability. Then you have professional values, norms, culture, and gender, which contribute to acceptability. Then you have geographic location, which we are talking more in this session. You have accommodation. You have hours of opening. I gave you example of a village called Dulepur, which was affected by hours of opening of the PHC. Then you have appointments mechanisms. Many institutions have started online appointment, but many people who do not have access to the modern methods may have difficulty in taking appointments online. Then you have direct cost and indirect cost and opportunity cost, which impact affordability. You have technical and interpersonal quality, advocacy, coordination, and continuity, which impact appropriateness. So at the bottom is the same thing again, which we saw in the earlier graph. You have healthcare need, you have perception of the need, you seek healthcare, you reach the institution for healthcare or the provider for healthcare, then you utilize healthcare, and then you have consequences. At the bottom, you have ability to perceive. It is health literacy. It is not literacy, it is health literacy. You may come across PhDs, doctorates who have no health literacy. In fact, they may have wrong ideas, and because of their education, they are able to justify wrong ideas very strongly. And it may become difficult for you to convince them. So it is health literacy, not just literacy. And an illiterate person may have better health literacy than an illiterate person. Then your health beliefs, the trust and expectations, then ability to seek looks at personal and social values, your culture, gender, autonomy, then ability to reach will look at your living environment, where do you live? Geographical access becomes an important factor here. Transport, mobility, social support. Then ability to pay, income, your assets, your social capital, health insurance. Social capital is something which is not as commonly understood. To give you an example, there is a person who has no money in the village, falls sick, but his neighbor comes, picks him up in his tractor or whatever transport he or she has, takes him to hospital. He gets the treatment and then brings the person back. This is social capital. They have good social networks in the village. When people move to urban areas, they lose out on social networks, and they may be better off in the village compared to when they reach a city and live in one of the informal settlements. They are not aware of the services. They don't know their neighbors. Even they know their neighbors won't take the trouble of helping them out and taking them to the health facility and getting them care. And then health insurance. Ability to engage, how empowered the service providers make the individuals who seek services. Information, adherence, whatever has been advised is followed by the beneficiaries, the caregivers, especially in acute episodes and in chronic diseases. Caregivers' role becomes very important, and we often ignore it. Caregiver support is very important, and we'll go into some more detail when we talk of family as a resource in caregiving. We don't have time to go into detail, but when you look at geographic disparity and you do root cause analysis, you will find that invariably it is sectors which are outside health which contribute to disparity. In this tree, you see chronic obstructive pulmonary disease, cancer, behavioral problems, depression, hypertension, diabetes, heart disease, obesity, injury. And then This time is employment, housing, social environment, built environment, education, violence in the society, and the trauma. And root are heterosexism, classism, racism, poverty, ableism, your ability or you are not able to do something, sexism, you have structural and institutional barriers, you have distribution of resources, you have ageism. Ageism is a new form of discrimination. People who are above 60 or 70, they are discriminated against. Adolescents are discriminated against. So that is a new form of discrimination we come across in healthcare provision. And when you have somebody who's 60 or 70 going to a healthcare provider, आपकी तो उम्र हो गई है साहब, आपको तो ये प्रॉब्लम चलती रहेंगी. How disheartened that person feels when somebody points it out to them rather than addressing their health issue and talking to them sympathetically. Then you have religious prejudices and then you have xenophobia. So you need to look at not just health outcomes, not just health behavior. You need to look at social determinants of health and go down to root causes of health and underlying systems and culture related issues which become more important when you want to have an equitable distribution of health. This is one of my favorite concepts. When you look here access, please look at the need of the whole population. And what does this contain? The whole population has four groups. One is the healthy population. They have no risk factor. They have no disease. You have to focus on them by doing what? By promoting healthy lifestyle and prevent risk factors, which is also referred to as primordial prevention. Prevention of disorders and health problems. Then you have population who have risk factors. They don't have a disease, but they are more likely to get the disease. For example, if God forbid, if both your parents are hypertensive or diabetics, you are more likely to be one. So what do? Continue with health promotion as we were doing in the first category. You need to take action on the risk factors. They already have risk factors. For example, they have high cholesterol. You need to address that. If they are more likely to get hypertension because parents are hypertensive, so they need to take care of their lifestyle more vigorously than the first category. Build resilience and maintain healthy lifestyle. And the third group is population with disease, but they are not aware. In many diseases like diabetes and hypertension, we know many people in our population have these problems, but they are not aware. They have never been tested. So what do we do here? We do early detection. And those who are detected, we give them treatment and care. Healthy lifestyle must be continued in all four categories. Healthy lifestyle is a treatment as well. It's important for prevention, but it's also important for treatment. Disability limitation and rehabilitation. And population who are known to have disease. Treatment and care. Compliance is a problem. I have come across very educated medical professionals who stopped taking treatment for hypertension. And when I asked this gentleman why did he stop taking treatment, he said, I've started doing Ayurveda. You continue with Ayurveda or yoga, but at the same time, keep an eye on the medical condition you have. Stop it only when a doctor who is treating you advises you to stop. So make sure that compliance is done. And in compliance, the family members also have an important role to play to insist the family member who's supposed to take medicine is regularly taking it. The family member who is supposed to maintain healthy lifestyle maintains healthy lifestyle. Disability limitation and rehabilitation is part of it. So unless you look after the whole population, you will have something like this. We are not addressing what is making them sick. And here is a quotation I have. There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river. I pull him to the shore and apply artificial respiration. Just when he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying, breathing, and then another yell again and again. I am so busy jumping in, pulling them to the shore, applying artificial respiration that I have no time to see who the hell is upstream pushing them all in the river. And a preventive approach will be let those who are clinicians continue to provide care to the sick, and those who are preventive medicine experts go upstream and prevent them from falling into the river. That will save 100% life. Even after treatment, the clinician will not be able to save every life. Clinician will not be able to bring everybody back to normal. But if you use the preventive approach, you will be able to keep them healthy for the rest of their life. And that investment will be very, very important. If you don't do that, this is what will happen. You have a picture here. The disease burden, the cart is every non-communicable disease, communicable disease, pandemics are being loaded on the health system. And where is the health system? This little poor donkey and the cartman are trying to put the health system back on track so that they can continue to bear the disease burden. So if you don't work on prevention, this is what is going to happen. Every hospital will get overburdened. You will keep opening trauma centers, accidents will keep happening. You will not be able to take them to hospital in golden hour because of the traffic. You will then have helicopters pick them up from the street and take them to hospital, to the rooftop of the hospital, and treat them. This is what is going to happen if you don't give due attention to prevention of disease conditions and keeping people healthy. Addressing geographical disparity, Baba Adam के ज़माने से हो रहा है. You look at Joseph Bohr's committee 1946, it talked about integration of prevention and curative services, providing primary health centers to start with, in one for 40,000 population and then one for 10 to 20,000 population, and 70. It has never happened. It has not happened even today. Then you have secondary care units, that's with 650 bedded hospital. You have district hospital with 2,500 beds. National health policy 1983 talked about health for all policies, providing access to every citizen, especially the vulnerable groups, women, children, etc. It was there in the policy. We are looking at disparity today. Similarly, national health policy to achieve acceptable standards of good health for population, focusing on increasing access to public health services and improving equitable access to different groups. National Rural Health Mission 2005, and which became National Health Mission 2013, was to improve the health status of rural population. And for a long time, we had rural population which was more deprived. Particularly focusing on women and children and providing access to affordable and quality healthcare. The emphasis on quality healthcare to make healthcare services accessible to rural population, especially areas with limited access, that is the geographical disparity. Special focus on vulnerable groups, empowered action group states. Uh, it came down from states to the block level, aspirational blocks, which was to provide more attention to those blocks. Am I still audible?
Yes, sir, you are audible.
Okay.
Yes, sir, you are
Just
audible, sir.
wanted to just wanted to check. Yeah.
Yeah.
All right. Then national health policy, we have talked briefly about it. Ensuring universal access to quality services. Increase health expenditure to 2.5. We are getting there. We're still not there. And we moved from selective care in primary healthcare to comprehensive primary healthcare. Then coming up of health and wellness centers, which were more comprehensive and included non-communicable diseases, mental health, and geriatric health. And these are now known as Ayushman Arogya Mandir. Then incentives for retention of doctors so that services are available in remote areas. Strategic purchasing, wherever services were not available for diagnostics or therapeutic, these were outsourced from the private sector. And then the talk about assurance-based approach, and which then resulted into Ayushman Bharat later in 2018. All of you are aware of this. Maybe you can take my class on this Pradhan Mantri Jan Arogya Yojana. You have primary health care. Primary health care, at the right bottom you see existing services RMNCH plus A. These were the services available. What was done in Pradhan Mantri Jan Arogya Yojana, the unmet need was also catered to, which included non-communicable diseases and other chronic diseases at community level by upgrading the sub-centers and primary health centers. And then primary health centers are the gateway. They need to be referred if services are required at higher level, secondary or tertiary level. Then you have Pradhan Mantri Rashtriya Swasthya Suraksha Yojana, Swasthya Suraksha Mission, which addresses geographical disparity by providing hospital care, and those who were deprived of the services can access those services. Services were covered up to 500,000 rupees, 5 लाख रुपए तक की सेवाएं उसमें कवर्ड थी. उसके बाद उसको कैशलेस बना दिया गया. So there has been a movement in addressing disparity, both geographic and other causes of disparity, and this became the mainstay of providing healthcare to the general public, and little later we will see if it has made a difference to the public. What was done for comprehensive primary healthcare? We had continuum of care, and we also included telehealth where services were not available. Then you had services which were expanded. Then you had more manpower available, and there were multitasking workers which were provided at the health and wellness center. There were partnerships for knowledge implementation, community mobilization, and health promotion. IT system was made robust, and financing and provider payment reforms were undertaken. And medicines, you have free diagnostics and free essential medicine being provided in primary healthcare system and at other levels in the health system in India. The packages, at the top you have care in pregnancy, neonatal infant health, childhood and adolescent health, family planning, reproductive health. You have comprehensive management of some communicable diseases, management of acute simple illnesses. The ones at the top were there to a large extent. What was added was screening and comprehensive management of non-communicable diseases, basic eye and ENT care, screening and management of basic mental health ailments, basic dental health care, geriatric care, and emergency medical services were added to the package of services, which became 12 from earlier lesser number of services. What are we doing to improve access? You have universal access as one of the principles of comprehensive primary health care. It has to be affordable. It has to be quality linked. Quality is very important for us to understand. If you do not have quality of healthcare may do more damage than help. So it's very important to not so in Ayushman Bharat. coverage of pre and post hospitalization expenses, which was not there in the beginning. It has been included now, 3 days pre and 15 days after hospitalization. Extensive coverage of medical procedures, and numbers keeps increasing. So it's close to 2,000 medical procedures which are covered. So all senior citizens are now covered, 70 and above. I am eligible for getting benefit irrespective of the income level. Nationwide access to healthcare benefits, portable. I can go from one state to the other. I don't have to be restricted to the state where I am domiciled. Cashless hospitalization has been started, and it has been able to reduce the financial burden on the families. We'll look at a slide later on if it has impacted out-of-pocket expenditure. So healthcare access, how it is being addressed? Improving healthcare infrastructure. You have increasing healthcare workforce diversity, starting with Ayushman Bharat, Arogya Mandir. Then you have financial assistance, and then you have addressing social determinants of health, which has been included in the policy and is being followed up by the government. Technology is going to help us in a big way, and many of you must have seen telepathology, teleradiology, teleophthalmology in various states. It was about 10 years back that I went to Tripura, and there were ophthalmologists only in the capital city of Agartala, in the two medical colleges. There was no ophthalmologist outside the capital city. But every person who came to a primary health center had access to an ophthalmologist through teleophthalmology. An optometrist was sitting at the PHC and with the slit lamp examining the eye of the patient, and the images were being seen by the faculty in a medical college in Tripura and in Agartala. And they were ones who were prescribing prescription, and when the consultation was over, a printout was handed over to the patient. 95% of the eye problems were dealt with at PHC level. Only 5% had to be referred to the capital city for further treatment. You have electronic health records, which are becoming more common. You have health information exchange, and we have wearable devices. And a future hospital will look from very different from what we have today. You may give the term virtual hospital to this hospital. Every one of us will be wearing a device which will be monitoring our blood pressure, blood sugar, and other vital aspects. And God forbid, I am sitting here comfortably in my study, and I get a call from an ambulance that I am on the way. You are getting signs of early heart attack. We will take you to hospital, and the bed is reserved in the hospital. And then I don't have to stay in the hospital all the time, only when it is necessary. The wearable device will pick me up, take me to the hospital, and I will be treated and brought back. So you don't have to queue up. And many of the tests which we have to go to the lab for performing those tests can also be done with help from wearable devices, or you can go directly to the lab without going to the doctor for consultation, and your reports will go to the doctor and you will get advice. So the crowd at the hospital, your trips to the hospital will come down, and you will get more prompt and more comprehensive health care. And that is the direction in which we are moving today. Then looking at what is going to happen, if you have interoperability and data exchange, that is happening to some extent now. Telehealth and remote monitoring we just talked about. You have artificial intelligence is going to help us in improving healthcare. Blockchain for data security and privacy. You have predictive analysis of population health. You can do genome analysis and see who is more susceptible to a particular type of a cancer or a particular type of a disease. That can be done. You have personalized medicine and genomics. Then you have cyber security and threat mitigation. With every advance, you also have some threats, and those threats need to be addressed. And that's happened today and going to happen more and more tomorrow. What is the traditional approach for reducing geographical disparity? All of us who have worked at PSC have been doing fixed day outreach clinics. We have been doing outreach sessions, immunization, antenatal, postnatal care clinics. We have used mobile clinics. We have had non-communicable disease screening camps out in the community. Government has also outsourced many health facilities to non-governmental organization or not-for-profit organization. Sorry for spelling mistake. Then government is also giving many health facilities in public-private partnership, and in many cities this is being done to a large extent. But in also in rural areas, public-private partnership is coming to address issues related to geographic disparity. Is it helping? Let's look at some of the data. You look at urban-rural difference in under 5 mortality. You have data from the NFHS1, which is 1992-93. The rural was about 60% more than the urban. What is it latest, which is 2019-2021? We don't have the most recent NFHS. But when that comes, I'm sure that will going to be showing some improvement. Current data 2019-2021 shows it is about 40% higher in rural areas compared to it was 60% higher about 20 years back. So that gap is coming down. Hopefully it will come down further. This is when we started Pradhan Mantri Jan Arogya Yojana, or National Health Protection Scheme. It was 37% were insured both by Pradhan Mantri Jan Arogya Yojana and other schemes. Uninsured were 63%. What is it now? Around 70% of people are covered by public and private health insurance. I was not able to check authenticity of the source from where I picked up this data, but certainly it shows a trend that more people are being covered by insurance, both public insurance, also private insurance now, as compared to what was being done earlier. So certainly we are making some progress in covering more population. Looking at out-of-pocket expenditure and government health expenditure on health, out-of-pocket expenditure as percentage of total health expenditure has come down to from 62% in 2014-2015 when we started doing national health accounts, to the most recent national health account data, which is 39.4%. So it's come down to about 2/3 of what it used to be. And government expenditure on health is increasing steadily. And the recent budget, for the first time, we reached 100,000 crores, 1 lakh crore health का budget था पिछले budget में. So it is gradually increasing. And out-of-pocket expenditure is coming down, and that's what we want to do, give financial protection to a common man so that they don't have to spend money from their pocket. And this is the point I wanted to make, that we don't look at family as a resource. It is the family where health or disease is produced and managed, not the hospital. Hospital only provides some support services. So let's bring the family back in the center. What do we do at family level? For example, in hypertension, lifestyle changes are enforced only at family level. What you eat and what you don't eat is done at the family level. Doctor doesn't come and feed you. Do you do physical activities or not? Again, is done at the family level. So we need to keep family in the front when it comes to adopting many of these healthy lifestyle changes. Treatment compliance is again done at home. I am hypertensive for how many years? 2008. कितने साल? 17 साल हो गए. I am on treat. I have gone to my physician only maybe 5 times. I have gone to cardiologist only 2 times. The rest of the time it is managed at home. Maybe I'm a doctor and my wife is also a doctor, so my visits are less. But for even a common person, most of it is done at home. So we need to bring family in the center. What is done at community level? What was done at family level, plus educating community, prevention and home care, and follow up of patients. Primary health care, they will do 1 and 2, plus they will diagnose, prescribe treatment if there is any need for change in medicine, or if there is a need for referring for complication, that will be done at the primary care level. Similarly, at secondary level, they will be able to manage conditions. And then other sectors, other departments, there's a lot more which needs to be done for health promotion by other departments than what is being done by health. So keep the family in the center, especially when it comes to non-communicable diseases and preventive and promotive aspects of healthcare. You want to look at more resources to look into more details of accessibility. There are 5 tools which are available on WHO website. You can look at them, and if required, you can use them. One is accessibility analysis. Second is geographic coverage analysis. Then you have referral analysis, you have zonal statistics, and you have scaling up analysis. These are the 5 tools which those of you who are interested in going into more detail of addressing geographical disparity can go into. This is one aspect I wanted to mention to you before closing. There has to be a leadership which is called leadership. In health system, the most important person who comes in contact with the beneficiary is either the doctor or the healthcare worker at health facility at the peripheral level. They may be referred to as street level leaders, and they are the ones who deliver services and deal with the grassroots realities. Frontline managers, those who supervise these frontline workers, connect the operational activity with the higher management level. So field level health workers may have solution to deliver services in remote areas, but may not be able to maintain standards due to lack of time, information, and other resources. So in health, we deal with what is distributed leadership. We have to keep in mind the most peripheral person who will provide the services to the population. Thank you. You want to have an ostrich ride? You are welcome.
Thank you, sir. It was a very good presentation, sir. And because I have worked in tribal, I have seen all these issues as well. And this was very enlightening. And I really enjoyed. I mean, my personal view is that we all enjoyed. Maybe everybody would have enjoyed the same. But it was like, it was so good. I can't tell you. I mean, to express my feelings is really, I mean, difficult for me as well. I have seen those things as you have seen, sir. I have also seen all those things, and well, while I was as advisor tribal affairs in Ministry of Tribal Affairs, so it was a good learning over there, which helped me out to make more things. People, this is for the first time when we were talking about the base management and to connect with people. So this time, for the first time in NHA, we have started with district implementing units. We are going to train these people in a better manner, that they learn how to go about their claims and other thing, the basic necessities they need to understand, and also need to understand the disparities what they have to face. So thank you once again, sir. And we have some questions. I think we can take it. Rishabh is there. Nanda.
Yes, ma'am.
Nan-
Any
Ask
queries from the participant?
Yeah, so
Yes.
Rishabh is there. There are certain people who want to talk about. So just give them a chance because there's a time to interaction. And
Sure.
thank you once again, sir. I
Thank
really
you.
thank you.
And my apologies for the initial hitch in
No, sir,
connecting.
not at all. And we are blessed. We are blessed, sir. We are blessed.
Thank
So,
you.
Nanda,
Yes,
you
go
can take
ahead.
up the queries, and sir will
Sure.
be able to answer well.
Certainly.
Yes, from Rishabh you can ask any questions from your side.
Yes, thanks for the opportunity. So thanks for Dr. Sanjiv for this insightful session. So, my name is Rishabh, and I'm from a health tech system, Vital. So, by this month, June end, we are bound to launch our NHA-backed PHR app, for availing the facilities of OPD registration, QR code generating EHR health electronic records, and digitizing the healthcare services. So like I like make made notes of all the things you mentioned. So I would like to ask, like a startup like us who want to launch this app and want to digitize the healthcare services at the rural population level. So since we think that the smartphone penetration, we don't know whether the rural population is friendly with the smartphone or not. So can you tell any strategies of what we should research upon to get a market penetration strategy for our app in the rural market population?
Thank you, Rishabh, and congratulations. You're doing a wonderful work, and technology is going to be the answer to most of the problems we face in healthcare delivery, especially addressing disparities. Two suggestions I have for you. I'm not a technical person in your area. One is keep in mind the most peripheral user. What are his capacities? What are his